Thank you so much to our chairman. Thank you to the moderators for inviting me to speak to this very wonderful group of people and this amazing city that I've recently gotten to know. So I will be discussing today a topic that is very interesting because I think it's not something we think about a lot, which is for upper tract urothelial cancer, how do we spare kidneys and how do we think about renal preservation? So we could easily title this talk, How to Maximize Nephrons in the Management of UTUC. These are my disclosures. So I want to start with some research my group has done to prove to you that this is an important problem. So why is it important to maximize nephrons specifically for upper tract urothelial cancer? So this is work done by Viam Sani, who's a medical student and now a resident at Cornell. And he looked at a database in the United States of patients who are undergoing transplant of their kidney, and specifically looked at the patients who have a diagnosis of kidney cancer, either upper tract or RCC, and said, what % of these patients go on to receive a kidney transplant? And what he found was that it was just 6% of patients who were made end-stage renal disease from a diagnosis of kidney cancer went on to receive a transplant, and actually only 10% made it onto a wait list. And unfortunately, these patients who had end-stage renal disease from a diagnosis of cancer, 50% of them were not alive within 5 years. And so I say that to you to tell you that sometimes our surgeries are perhaps not doing our patients the service that we may think they're doing. And so we need to challenge ourselves to think of alternatives. So these are the AUO, SUO guidelines, specifically as it relates to kidney-sparing management for low-grade cancer. And I'll be discussing this talk in both low-grade and high-grade, because I think those conversations are a little bit different for upper tract urothelial cancer. So for low-grade disease, tumor ablation should be the initial management option for these patients. And typically that will be endoscopic, but we can discuss alternatives. Tumor ablation may be the initial management option for patients with low-risk, unfavorable UTUC, and select patients with high-risk, favorable disease who may not be a good candidate for nephroureterectomy. It can be accomplished via a retrograde or a percutaneous approach. So when I think about considerations in low-grade upper tract, oncologic control is obviously paramount, but I think we need to remember that the risk of a patient progressing with low-grade disease is not very high. The risk of a recurrence is quite high. And so when we think about it in that context, based on what I just showed you about if we remove these kidneys, the chance that they'll receive a transplant or the chance that they may make it that far is not very high, then I think it's obvious to us that, okay, endoscopic management is the rational management of choice in the majority of these patients. But not all patients. So there are times in which surgical extirpation may be indicated and in which other surgical modalities such as segmental resection is indicated. I'll be focusing for low-grade disease on two drugs, one of which is FDA approved in the United States and one of which is emerging for this low-grade upper tract arena that is up and coming. Because the problem with endoscopic management is it works very nicely once or twice, but over time, repeat endoscopic management of low-grade urothelial tumors leads to complications, leads to ureteral strictures, leads to perhaps later on complications that we would not want for that patient. So the ideal is tumor ablation via many different modalities. We'll go over two. So this is a study of primary chemoablation for low-grade upper tract urothelial carcinoma utilizing UGN-101, which is a mitomycin-containing reverse thermal gel. And the way this works is it's mitomycin impregnated in a reverse thermal hydrogel polymer that is given in liquid form and upon being delivered slowly becomes a solid and then releases as a depot back into liquid form, delivering the mitomycin agent. So this is given this was given through a stent in the renal pelvis as part of this trial. And what this trial demonstrated that ultimately led to FDA approval was a complete response rate of 59% and a durability of 70%. So it worked actually quite well for these patients, and we were part of that trial. And the critique was that there was toxicities, specifically ureteral spasms and ureteral strictures. And my response to that at the time was, yes, but there's not a comparator group of patients who underwent repeat endoscopic management. They too would have had complications such as ureteral spasms and ureteral strictures. So I think this is all to say that this is one modality for management of low-grade upper tract urothelial carcinoma, and indeed we use it at our institution quite often. Where's the slides? Okay, I'm going to keep moving on. So for high-grade upper tract urothelial carcinoma, what can we learn about how to spare the kidney that can teach us, what can we learn from systemic agents about how to spare the kidney? So very different from low-grade disease, where we're talking about ablating tumors. High-grade disease is very different, and the reason it's very different is because we know that when we have a specimen from a uteroscopy or a biopsy, the rate of understaging is quite high. So it may come back as a high-grade TA tumor or a high-grade T1 tumor, but we know that at the time of nephrouterectomy, it's oftentimes T2, T3. And so clearly, endoscopic management alone is not going to be good enough. The rate of node-positive disease in these patients is very high as well. And so clearly, some type of systemic therapy in our armamentarium is quite important. And this just highlights the rate of upstaging in an upper tract disease compared to bladder cancer. When it's in the bladder, the rate of upstaging perhaps 10%, whereas upper tract urothelial cancer much, much higher. And much of what we know about systemic therapy has been historically in the adjuvant setting with a trial called the POUT trial, which demonstrated efficacy for chemotherapy after removal of the kidney for upper tract urothelial carcinoma. The problem is many of these patients cannot get cisplatin-based chemotherapy, and indeed many of the patients on the POUT trial were converted to carboplatin-based chemotherapy because their kidney function was not good enough. And so this is an estimate from a study that shows that the amount of patients with UTUC who could undergo adjuvant chemotherapy is approximately 58% pre-op, but post-op, after their kidney is removed, it's only 15%. And so what can we learn about systemic therapy outcomes to teach us about the opportunities for kidney preservation as we, according to this symposium's title, look into the future? So when we look at neoadjuvant versus adjuvant, really one thing that's striking is historically there's more data with adjuvant therapy. I discussed briefly the POUT trial, which demonstrated EFS, 3-year EFS benefit of 71% for chemotherapy versus 46% without, so pretty significant. But unfortunately, many of the patients did not have kidney function good enough to receive that therapy, as I said. Also, nivolumab is increasingly being utilized in the adjuvant setting for bladder cancer as well as upper tract urothelial cancer, and also has demonstrated a durable disease-free survival interval. But in neoadjuvant therapy, which I want to focus on for the purposes of this talk, we have data that suggests that the path CR rate, depending on the study you look at, is probably somewhere around 20%, meaning patients who would be treated with chemotherapy and then have their kidney removed would have no cancer in about 20% of cases. And so this is very encouraging for us if we're trying to think about how do we spare the kidney to use this kind of data. And all of this has recently changed. Why has all of this recently changed? Well, in the last month, 1 month ago at ESMO, probably the most important finding in this space in the last several years was reported, and that's EV-302, which was a trial randomizing EV-Pembro versus chemotherapy for frontline metastatic urothelial cancer. And what it demonstrated was a complete response rate of 29%, an overall response rate of 68% versus the historic, versus chemotherapy, which was far worse. And when we think about, and this is just once again demonstrating that difference of 68% versus 44% in this trial. So why am I showing you this data? Well, I'm showing you this data because one of the next slides I'm going to show you is going to try to put all of this together to say, okay, thinking about renal preservation in the future for low-grade disease, that's a little easier. We can ablate these tumors with medication, with lasers, but thinking about renal preservation for high-grade disease, high-risk disease is much harder. And what can we go on? We can go on the chemotherapy trial I just showed you. We can go on EV-Pembro, which I'm trying to show you now. And so this is a trial that at our institution we've put together recently that puts this all together. So this is called the Renal Retention Trial. It is primarily run by two of my phenomenal partners and colleagues, Dr. Nirmish Singla and Jeannie Hoffman-Sensis, who are the primary team running this. And it takes patients with UTUC and gives them EV-Pembro. And if they have a CR or a partial response, and I just showed you data that in the metastatic setting, that group is somewhere in the 70% range, so we hope this is the majority of patients. They continue on the trial, their kidney is not removed, and they are continued on maintenance therapy and observation. And if they have progressive disease at that point, then their kidney is removed. And there's a high sequencing component to this and a translational component. But this is where, in my opinion, the field likely should be heading as we work to utilize the amazing success of our systemic agents to try to reduce the amount of our patients that we're putting on end-stage renal disease, on dialysis, and on untimely death from their kidney disease, not from their cancer. So I will just leave it at that. This is our multidisciplinary care team at Johns Hopkins. We have an upper tract multidisciplinary clinic that meets twice a month that is only patients with UTUC, with medical oncology and urology working together on these patients. And it's an amazing effort of our group, and this talk is very much a product of this team effort. Thank you.